Before we came up today, I had the opportunity to have a conversation with our keynote speaker, and I'm going to introduce him with words that explain what he looks like on paper. But I can also tell you that in conversation with him, he is passionate about the issues that we are passionate about, and so I'm really looking forward to his talk today, looking forward to hearing some hopefully provocative remarks and sort of pushing us all forward in terms of improving primary care in Canada. So I'll tell you a little bit about him. Mr. Lewis is a health policy and research consultant. He's based in Saskatoon, and also the adjunct professor of health policy at the University of Calgary and Simon Fraser University. So he's a very busy man. Prior to resuming a full-time consulting practice, he headed a health research granting agency and also spent 7 years as the CEO of the Health Services Utilization and Research Commission in Saskatchewan. He's also served on various boards and committees, including the Governing Council of the Canadian Institutes of Health Research, the Saskatchewan Health Quality Council, the Health Council of Canada, and the editorial board of several journals, including the newly launched Open Medicine. His published works cover topics including reforming and strengthening Medicare, improving healthcare quality, primary care, regionalization, and the management of wait times. So you can see there's several things that we're very interested in that are at the core of what he does. So Mr. Lewis's address today is entitled Eminent Domain, How Family Medicine Can Reclaim the Future. So please join me in welcoming Mr. Stephen Lewis.
Thank you very much, and it's a real honor to be here. I negotiated that I was allowed to take this off to give my talk, since it's not my normal garb, and I normally do this in a phone booth, but thank you.
Flash to people, yeah.
As I say, thank you so much for this opportunity, and it is an honor indeed. As to the question of how provocative I'm going to be, probably a little less than I might have been, now, given that there's so many people sitting behind me and we didn't do an arms check, so for my own sense of safety, I will be middle of the road. But in all seriousness, what I want to do this morning is to move from the panoramic view of the healthcare system, which is been one of my preoccupations for my career in health policy and health services research, and then move in towards your particular role. And in my title, when I talk about eminent domain, my premise is, and where we will end up is, I think, and I genuinely believe, and I'm not just saying this because I'm talking to you, the future of the healthcare system lives or dies with you. If primary health care does not succeed in being the engine of health system renewal and reform, all the bets are off for the rest of it on sustainability, cost effectiveness, and more to the point, quality and outcomes. So I'm going to start with some homey truths here. I'm going to apologize in advance in that these are, I'm going to have to oversimplify. I only got about 20 minutes, and I do want to leave room for questions, and there will be microphones here. So I'm going to have to make some generalizations that can't possibly be true everywhere, but I think they are largely true, and my sources here are the pretty well-known research evidence as I go through them. So when you look at the Canadian healthcare system in general, it is not that pretty a picture. In any international comparison, we fare relatively poorly on domains such as access. All attempts to measure value for money, although they're a little bit dodgy methodologically, place us near the bottom of the OECD pack. We share with other advanced OECD countries widespread evidence of indifferent quality and persistent safety problems. This isn't unique to Canada, but we still haven't managed, despite the incredible talent in the healthcare system, to achieve what should be pretty standard things like 100% rates of hand washing in hospitals and so forth. We still practice without decision support software in the pharmaceutical area, which is why polypharmacy is among the leading causes of hospitalization and other morbidity, particularly among the elderly. The greatest needs in the healthcare system and emerging needs are people with multiple chronic diseases, and again, the research evidence is pretty clear. Quality of care in the middle of the curve is not very good, and if you have 3 or more chronic conditions, you're likely to be in pretty bad shape. We have, of course, phenomenal pockets of excellence in Canada, and I'm sure many of them are represented in this room, but our problem is spread. We have not yet achieved system-wide excellence in any given area. So there are a number of root causes of this in my view, and again, I certainly invite you to think about these and to challenge those that you might not agree with. One is, as those of you who have gone through it, and you all have know, it is very difficult to align the health science education curriculum with the population health needs. So the amount of time that a family physician or an undergraduate medical student spends studying geriatrics and chronic disease management, it remains vanishingly small compared to studying the traditional aspects of medical training. A second reason is that for our problems in the system is that family medicine remains significantly an independent, quite autonomous cottage industry. The level of attachment of family doctors to the Canadian healthcare system is probably lower than that of family doctors in most other countries. Obviously, it's considerably lower than in the NHS, where physicians have considered themselves since day one to be front and center and part of and embraced by the NHS. The negotiation in Canada at the dawn of Medicare was for physicians to be arm's length, generally quite autonomous, and not in any sense fully attached to the healthcare system. And I think we're paying a price for that. The great quality guru, Dr. Donald Berwick, says that autonomy is the enemy of excellence. We also, and again, you have lived this life yourselves in this room, and I empathize a great deal with the history here, that despite the recent gains in family medicine, in the distribution of resources, we still have a reward system that is misaligned with our goals. Within medicine, it is only lately that some of the gap between family medicine pay and specialist pay has begun to narrow. But I think there's a bigger problem in the distribution, both within and outside of family medicine. So when you have a dominant fee-for-service payment system that is unable to move towards a relative value fee guide, what you essentially get is that the physicians who are willing to spend a lot of time dealing with very complex patients make a lot less money than people who churn through 60 a day and do rather simple things. This is disheartening, no doubt, to many physicians, and it's also more ominous for the public. We can all speculate and have an opinion on how good or not so good the healthcare system is, but the reality is that, again, by international standards, we have precious little valid, comprehensive information about the quality and the outcomes. We are lagging in the international health information system improvement movement. We tend to share last place with the United States, although they have crept ahead of us. But neither of us is anywhere near European standards, where there are countries where 99% of physicians use an electronic health record. Family physicians in Denmark estimate that the presence of an electronic health record saves them an hour a day just on communications. And finally, we have a system that is fraught with variation, error, and problems in quality. You cannot do a study of small area or geographic rates of intervention for any kind of either disease pattern or procedure without finding a threefold, usually, variation in the highest to the lowest rate when you adjust the population for age and sex, and in some cases, health status. As you know, variation is the enemy of quality. If you don't standardize protocols to a certain extent, if a patient with similar characteristics gets treated in a vastly different way in one jurisdiction than another, they can't both be right. Yes, there is a great deal of uncertainty in medicine, and I don't suggest that all of medicine is amenable to clinical pathways and clinical practice guidelines, but even where we have them, the adherence rates are discouragingly low. So I think this presents a pretty major challenge for family medicine. And I think I would invite you to consider a few possibilities here about the current state and the diagnostic. First is, in the last 20 years, again pretty well documented, the domain of family medicine has shrunk. It has shrunk for some pretty understandable reasons. The burgeoning technology in medicine and the emphasis on high-end imaging and other diagnostics that has tended to be the domain of specialists has meant quicker referrals to specialists. I don't think as a patient that this has necessarily been a good thing. In fact, I think on balance, and I'll get to this towards the end as well, I think it's been an excess of hope over experience. And I think that if we don't retreat a little bit from that quick referral to specialties, that the prospects for success are much, much less than they ought to be. So if this is the case, if the domain of family medicine is shrinking at the same time as medical school enrollments have increased by 84% in the last decade, and the annual production of new doctors has nearly doubled when you consider the easier path to licensure for IMGs, we have ourselves a dilemma. We have had a narrative of scarcity in medicine generally and in family medicine in particular for 25 years in this country. Well, though you may disagree, I'm here to tell you that the shortage is over and the surplus is upon us. It may not be apparent in your communities, particularly if you're in rural and remote Canada, because we never have and are unlikely to get the distribution right given the current policy environment. There's nothing that prevents all new graduates from flocking into the cities as they have historically done. But sooner or later, it's going to come home to roost. It's already come home to roost in some specialties. New cardiac surgeons and new orthopedic surgeons are having a very difficult time getting jobs. You may have read the Royal College report that suggests that 1 in 6 newly minted specialists do not get a job. It's only going to get worse. Now, from the standpoint of the public, you could almost say that it's only going to get better because having too many is better than having too few. But it does create a bit of a crisis in the future of medicine because there will be more competition for the terrain. There will be specialists who, as they do in some parts of urban Canada already, begin to dust off their generalist skills in order to practice essentially family medicine because there isn't enough work for them in true specialty care. So this creates a division of labor issue that I think we are just at the beginning of facing. And I think it's going to be a big challenge that will accelerate over the next 5 years. The other challenge, of course, is that in health human resource planning, we have always considered, when we made decisions about ramping up enrollments in various disciplines, that the division of labor would not change between medicine and others. There are at least 40 high-quality studies, as many of you are aware, worldwide that show that nurse practitioners and others can do a great deal of family medicine and primary care very effectively. And I think this creates a dilemma and a challenge for you, which is finding your unique role in a future where you can no longer assume that tradition and traditional prerogatives will remain in place forever. There is only so long that any occupation in any industry can fight off legitimate competencies that are held by others to practice in those realms. And this is a big challenge, I grant you, for family medicine. If the game is that some specialists are going to start treading on the traditional domain of family medicine, if other occupations are ramping up their entry to practice credentials, as they are doing, in order to play greater roles in primary health care, what is your unique role? Where is your unique value added to the system? It's a real challenge. And finally, as we contemplate the future, we have to look at the future of regulatory agencies and what they might do in this regard. Again, I think it's very difficult to anticipate the future here because there are a lot of uncertain variables here. But if there is going to be a democratization of competencies, I think it's going to change what you do, and it's going to present some organizational challenge that you can regard as either threats or opportunities. I think we will see a decoupling of credentials from scope of practice. Not tomorrow, not the next day. Already provinces like British Columbia and Ontario have health disciplines legislation that permits a much more fluid and democratic assignment of competencies than exists now. That legislation and regulatory modification does not necessarily translate into action. I don't think we're there yet. I don't think we've seen anywhere near the consequences that we will see in 5 or 10 years. I think there will be a shift from the notion of standards that are associated with professional identities to evidence-based practice standards. And I think that, again, will create among the public a lot more confidence that other occupations can play significant roles that they are now, by tradition and organization, not allowed to play. And finally, there is going to be, I think, a very serious conversation about the future of clinical autonomy and what it means. Autonomy based on evidence-based practice, transparency, and accountability is a wonderful professional characteristic. Autonomy that results in unjustifiable variation in practice, safety problems, inadequate care is not. And I think what we want is to preserve the best of professional autonomy and eliminate the autonomy that simply means that a whole lot of practice is not evidence-based and a whole lot of preferences are underlying what is done instead of the best available evidence to guide practice. And though this is the topic for another day, I actually think that in 5 to 10 years, we may see serious inroads into the whole notion of professional self-regulation across the board, not just in healthcare, because I think with the regulatory failures in the economy, the Lehman Brothers, the Enrons, the accounting, all of these scandals, I think, have diminished public and political faith in the ability of any occupational group to regulate itself without outside participation. So if that's a little bit gloomy, let me get to the part that I think gives me hope and gives me optimism. I think there are, despite all of that clutter, which is, I think most of those are issues that you will one day have to deal with, there are spectacular opportunities on the horizon. First of all, and this isn't so good for us, the citizens, because we are as the patients, but there is a vast amount of unmet need out there that somebody has to meet well. I mentioned before, they're probably clustered in multiple chronic disease management, mental health issues, and even in a wider sense, addressing health disparities in the population. If family medicine becomes the champion, the advocate for, and the expert in a population health approach to care, then we're going to have an explosion of excellence in Canada, the likes of which we have never seen, and we will catapult ourselves to the top of the league tables where we are now near the bottom, alas. If family medicine is able to influence health science education across disciplines to take these issues as seriously as they ought to, if it has a tremendous impact on the organization of the curriculum, how practice experience is acquired, and more to the point, what defines performance in healthcare, I think it will be your golden era. If we do not achieve that almost intellectual and conceptual revolution, we have trouble. We, the citizens, have a big trouble on the horizon because we will be larger and larger in numbers. And I'm not worried about the financial implications so much of an aging population with these conditions as the human toll taken by them not being addressed well. And I think this is your domain, this is your terrain. The family physician of the future will be part geriatrician, part psychologist, and part coach. Because the coach part is that the ideal form of interaction and the ideal partnership with patients like me is to get me to self-manage, to abandon the work. The second opportunity that I think is on the horizon is there is a growing interest in and somewhat of a swinging of the pendulum back to generalism. We have operated under the paradigm in Western medicine for the last century that increasing specialization and subspecialization has been a good thing. I think the jury is pretty much in on that one now and that it hasn't delivered on its promise. Yes, there are medical miracles. Yes, there are technological miracles, and I applaud all of them. But the average, everyday epidemiological landscape doesn't look like miracle medicine. It looks like aging, chronicity, mental health, all interacting with the non-medical determinants of health. That requires a generalist. Relationship-based medicine requires generalism, constancy, continuity, and a team-based approach. Again, this is a spectacular opportunity for you. If you lead the vanguard, if you are in the leading charge towards a reconceiving of what primary care practice is towards this model, you are going to repatriate a lot of work from specialists. And I'm not saying that this is a great thing for specialists, and I'm no big fan of physician unemployment, but for the future of people with these kinds of needs, once they get away from your domains, once they are referred on from your clinics and go into that very difficult to navigate world of specialists and subspecialists, we are in trouble. The complexity of the care plan is a risk factor for us. We need your generalist skills to look after us and also to pay attention to our preferences in the sense of sometimes we don't want all of medicine's vast artillery deployed ostensibly to help us. Sometimes we need to be left alone. I say this with some trepidation. My 90-year-old mother turned around her care when she threw her medicine lockbox off her balcony. Mercifully, there was neither a human nor a vehicle below. But she demedicated herself, and after spending 2 years as what I realized to be a non-patient-centered son, urging her to accept the ministrations of the system and not listening to her preferences, she got off her medications and she's never been better. She knew best. This is a not uncommon phenomenon. I want to return a little bit to the reducing health disparities. Obviously, family medicine cannot by itself reduce health disparities because to reduce health disparities requires a reconfiguration of how society distributes its goods. But you can be much more intersectorally oriented, and you can organize yourselves in polyclinics and in intersectoral planning and delivery structures that at least make sure that people's needs are being addressed by somebody, even if that somebody is not you. This is an enormous issue. The biggest healthcare problem in Canada is not heart disease, it is not cancer, it's not even mental health. It's inequality. And if the College of Family Practice, provincially and nationally, if the 35,000 family physicians of Canada became strong advocates for a different concept of social justice and cementing the relationships time and time again between the non-medical determinants of health and what you can and cannot successfully deal with, I think you are going to not only produce better health outcomes, you're going to produce a better country. And finally, I think you can reimagine the division of labor that will actually make your lives better. There is nothing better for a professional than working at the top of one's scope of practice. Most professionals in Canada work towards the bottom of the scope of practice because the incentives are in that direction. And I won't go into the details here, but you actually do better financially if you do simple, routine, and repetitive things like knee arthroscopies than if you do more complex cognitive work, which a lot of you do, of course, in family medicine. It's also the case that there is little more demoralizing than not being able to deploy all of one's knowledge and skills, which is the case not only for many physicians, but it is certainly the case for many other occupations. So this is more about you than about me as a citizen. This is more about your own professional well-being. I think if you are able to do intellectually stimulating complex work as the core of your practice, if you focus on those areas of uniqueness that only you can do because of your knowledge, your experience, and your commitment to a generalist and holistic view of the human condition, I think your practices will be incredibly rewarding. I know some of them already are. And I know that practices need variety. We can't all spend all of our time on incredibly complex things. But by and large, there is a vast, vast unmet need there that you can't possibly do on your own anyway, and that working in a high-functioning, self-organizing team that blurs the occupational boundaries, that rewards people's lifelong learning and experience, and that allows intelligent people to find a care plan for people who have very difficult circumstances. I can't imagine anything more rewarding, and I think you should embrace that. So what are these paths to the preferred future? Well, first of all, and I know this will be a stretch for many of you, I think you have to get into the game. You have to get into the system and you have to attach to it in a much more real way than you are now. I think you need to be attached to either a regional health authority, a local health integration network. Not for the purpose of them looking over your shoulder and demanding pseudo-accountability from you, but to own the system's problems and to co-create the solutions to them. I want you to be front and central. You cannot be front and central to their solutions if you are at arm's length. Secondly, I think you need to own the indicators. I'm a little bit worried as a health services researcher and data geek with the indicators that are emerging in our system. I don't think it's a big triumph worth extra money to do pap tests at the right intervals or to do hemoglobin A1C testing at the right intervals. I think the heroic work that I want to see rewarded is helping someone to live 10 more years without severe complications of 2 or 3 chronic diseases. I think it's heroic when you get patients to self-manage and they are not so dependent on you. We have no way to reward those things right now. In fact, we penalize them as much as we reward them. So if we're going to define productivity in healthcare, and if we're expecting more accountability for performance and value for money, it seems to me we need to get those measures and indicators right. And I really hope that you will embrace that as a fundamental job and that you will do your best to influence the policymakers and the decision makers and the auditors general and the accountants to take note of what you do and what you ought to aspire to do, and that the indicators, even if they're hard to measure and even if attribution is difficult, they need to measure the right things. And the right things are often less tangible, they play out over longer periods of time, and they're not counting statistics. Third, and again I will get into a little bit of hot water here, I think you have to lead the charge to completely reconceive the collective agreement between governments and medical associations. I think they are all broken. I don't think they reward the right things. I think they have perverse incentives. And I think they spend too much time monetizing concerns that are not really about money, but they end up being about money because that's what you negotiate at the table. I think that's corrosive. I think it's morally corrosive. And I know that's a strong term, but I think what it does is it unconsciously encourages good people to do dodgy things. And it rewards the worst in us, and it does not reward what is best in us. I just think that's no longer sustainable. I have looked around the world and in some cases paid site visits to what are widely regarded as high-performing health systems. And I always ask the physician leaders, could you get this done on fee-for-service? And they all say no. The American Society for General Internal Medicine has come out with a report that flatly says that the first priority is to abandon fee-for-service as quickly as possible because it is no longer compatible with system goals. So, to conclude, you're the future. Nothing is going to transform in Canadian healthcare without you. If you are the champions of comprehensive care and the champions of population health, you will literally rescue the Canadian healthcare system from the moribund state that it finds itself in despite doubling expenditures in real terms in a 15-year period. If you lead the move towards a more open and transparent health information culture, you will allow us to understand, and you will understand yourselves, what high performance really is. If you expand your generalist skills and work in teams, you will repatriate work that has been lost to specialists. And if you lead the charge for a needs-based health science education curriculum, you will transform medical education and produce the great doctors of the future. Thank you for your attention, and I look forward to talking with you either in this very large and forbidding room or in the hallway after if we have the time. So thank you very much. Well, I think we do have a few minutes, and we have microphones, so yes, great. I can't see very well, so you have to sort yourselves out which order you've arrived. Right. Oh, there we go. Good. Thank you.
First of all, I'd like to say thank you for a very thoughtful speech. I'm wondering if you could tell us, if you take some of the countries that are regarded as having the highest performing healthcare systems, France, Denmark, some of the European countries, what are the top 2 or 3 things that they're doing right that we're not?
I think if you think, and the one I will know best, and I'm not pretending that any country is uniformly high performing. In fact, the highest performing systems, I believe, are subsystems in the United States, like Kaiser Group Health, Geisinger, et cetera. But what they do a few things better. They organize their care better. They are always much more team-based, with the exception, in a sense, of France, which is not so team-based. And it's a bit of a mystery about France's health system performance. I think largely it's more a question of better health status. But they're all much more accessible. Like their wait times for just about everything, and particularly for primary care, is very, very short. Same day, next day access for sure. Secondly, again in the UK, they have a much more effective division of labor. So the chronic disease management in the community is done almost exclusively by nurses. They have much better health information systems and electronic health records. And the distinction and the hierarchy between primary care and specialties has largely broken down, and the pendulum again has swung towards a greater investment in primary care. And in the American systems, what they do best is they take a whole systems governed approach that is quite vertical. So why is Kaiser no more expensive than the British NHS, which is remarkable given that the American health system costs twice to 3 times as much as the US? It's because they really figure out how to do things upstream, and they put much more investment in keeping people out of hospital and out of long-term residential care. So what we tend to do is we will deploy phenomenal amounts of resources for people who walk into an emergency room clutching the chest, but we are very, very stingy with home and community care and social supports, and we end up paying the price all the way down the road.
Thank you. Thank you. That was excellent, and many of your words spoke very true. Jeffrey Simpson wrote an article this week about BlackBerry and Nortel and the Canadian culture that we just didn't innovate in those companies and that we were complacent. Are we being complacent? And given that we are a federation of all 10 provinces and territories, how do we affect this change as a discipline broadly across Canada?
Yeah, I think our problem, and it's a terrific question, and it would take an hour to answer it decently, but in a nutshell, and again, forgive the oversimplification, we are way too proud of Medicare as an icon, and we are too indifferent to the fact that it isn't very comprehensive compared to international standards, and it's badly organized or unorganized. So we're extremely complacent about that, and we beat our breasts with pride about Medicare, Medicare, Medicare. And as I was saying to my colleague waiting in line, about if you don't need a hospitalization, Medicare is a pretty thin veil for meeting your health care needs. So much of it has been privatized by stealth. And secondly, it's not that we don't innovate, it's that we don't spread it. So there is no problem with some pockets of early adopters doing some really marvelous things in this country, and some of you are in this room. It just doesn't spread into the policy realm. And again, I think that's a structural problem with how we negotiate health reform. And I think we have thought for too long that the solution is to buy our way out of the problem, and it hasn't worked. So yeah, we have a huge innovation problem, I believe.
Thank you very much again for a very thoughtful and reflective talk. This isn't really a question; it's a comment, and I wonder, with your using multi-complex patients and the problems with geriatrics as the population ages, I think your same things still also apply to the other end of the spectrum, and that's the young, the very young. We know more and more that healthy child development influences physical health, mental health, and everything for the whole lifespan through epigenetics and how things are expressed. So I think we have to watch in family medicine that we don't give that part away to others as well, because we really, working interprofessionally, it's very important, but I would not like to see us become just the people that look after the multi-complex and the elderly.
Couldn't agree more, and that's a family issue too, right, and determinants of health, so I agree with you. Have we got a technological malfunction? Oh, okay, so we'll get you, so someone at a live mic?
Yeah, I think I'm alive here. Two related but quick things. One is I wonder if you're speaking, and you're speaking so well and so clearly, but it's appealing to us because we actually already are the people in Canada practicing in teams looking after complex patients. And one of the difficulties we face as family physicians is that there's an almost equal number sort of hidden in the system of people who really are general practitioners. Colleagues graduated when I did in '73, went into solo practice directly, no family medicine specialty training, failed out of neurosurgery, failed out of oncology radiation. The specialists, but they aren't even specialists, who've gone into general practice. And I think it's a very difficult, and as Canadians we're too polite even to address the fact that that's a very large number of physicians in our system. We need them in many communities. They tend to be practicing on the outer edges of a lot of places. They're not the main downtown physicians in the teaching hospitals, for example. So I think that's one really big issue that's hard to address, and I don't want to be stereotypic, but it's also a sort of unmentionable in our system. We don't want to stereotype people, and we shouldn't. Also, as I sit down, I want to say, I wonder if the disruptive technology we better also watch out for is, you've used the word psychologist to discuss us. I'm not a psychologist, I'm a physician, and I think the changes in neuroscience that are going to be scientific, medical kinds of things could completely change all our paradigms in the next decade.
Well, I won't comment on the first one, but I think you're right to have the conversation about there is not one species of the genus family medicine. But on the neuroscience thing, I'm not so sure. I'd hedge my bets on that one. And the reality is, if we mean what we say about patient-centered care and patients as partners in our own care, you have to be psychologists. It's my motivation and understanding that is going to determine my fate as much as the ministrations of the technological end of medicine, and somebody has to do it. And if you're not going to be the coaches, fine, but then you better be in a team where somebody is, because that's the only way we can make real my capacity to be a co-creator of my own health.
I'm a family physician in a small rural community, and I'm struck by the number of things that you're talking about that we're in the process of working towards and implementing. And we're in the enviable position, I think, of being in a closed system, as you know, as a small group of family physicians, one hospital, and being able to work in team-based clinics. But the one thing that plagues us is the distribution problem that you mentioned early on, not just of physicians, but of all healthcare practitioners. I wonder if you have any thoughts on policy and how that might move forward in the future.
Again, and forgive the provocation of this, I see no solution to the distribution issue unless there is a policy that actually mandates it. Teachers don't get to decide to hang out a shingle in downtown Toronto if the schools are full there. They have to go to where the jobs are. And if governments and medicine and other occupations don't negotiate some means of ensuring a distribution here, and I know the controversy and all that, I get it, then we'll never solve it, because we never have. I mean, there are still vast areas of this country that are underserved despite the enormous new influx of physicians. So I don't see how you square the circle unless there is, by region or by community, essentially a quota system about how many physicians and others you need. It's not unique to healthcare, by the way. Professionals in any occupations are not flocking to small town Saskatchewan. The whole world is urbanizing. And if we're going to keep those communities sustainable and good places to live, I think we're going to have to think very creatively about how we do it. And we've tried everything short of mandatory to do it. We've done the bribing, we've done the practice investments, we've done everything possible, and it doesn't work durably. So I don't see another option.
Alas, I'm here to put your coat back on. Dr. Lemire, please.
You can hang on for a minute. So, like other members of our staff, I was a little bit concerned when I welcomed Mr. Lewis as a plenary speaker this morning, just wondering how provocative he was going to be. But I think that I feel reassured and certainly want to thank you on behalf of the college for sort of adding to our carte de route, our roadmap, and for giving us some wonderful opportunities to think about and work with others on implementing in the future. So thank you very much.
Thank you.